topic in regard. As yesterday we heard that there are so many alternatives. So long-term assist device and weaning from assist device. So do we really need transplantation in the end of the treatment which we discussed yesterday of heart failure? And I think, yes, we need. As we see also there's a need for bridge to transplantation. But nevertheless, we have to discuss what is possible with transplantation and what are the problems with transplantation, and especially do we have learned something and can we also improve? That's what may happen after transplantation. So the talk is about long-term outcome and how the change of long-term outcome was. So outcome is defined by a result according to a therapy or anything which we do to a patient, and I think outcome is really difficult to measure. And we can measure it by the patient. If the patient is reporting to us, so my outcome is better, or my feeling is better, or my clinic is better, or my status. It can be defined by an observer, so an observer can just neutrally, just not involved in this treatment, report on that. And the majority of that's what we report on outcome is that the clinician, so we are reporting on that outcome. So this is the majority of studies, and that's why we always stick to that part of information and wanted to do improvements on that also. So there's an indication, and it's a big list of indications. I just want to briefly show you that normally it is transplantation is needed if we have a deterioration of ventricular function, most likely not responding to any kind of treatment which we're doing. So it's not in regard to the history or even not in regard to the genesis of this. So it's a ventricular dysfunction, either one ventricle, either two ventricles. And most likely in pediatric we have a special need to look for is the growth failure. So if the patient is not growing with this ventricular dysfunction, especially in the heart failure, then most likely we have a need for changing the therapy in regard and go over to maybe the possibility of transplantation. Arrhythmia or even ongoing intravenous support, inotropic support would be another reasons. And some others like the protection for the development of hypertension, pulmonary hypertension would also be. And we have those patients on the VAD, which we just heard yesterday, which have some options, but some of those may not be possible to wean, so then those patients may be bridged to transplantation as the VAD was originally designed for. So if we think about outcome, so if we do nothing in those patients, we know that there is a majority of patients which will fail to survive, so the survival will be lower than even if we do transplantation. This is an old study from 1995, published, but it was comparing the transplantation in regard to any conservative medical treatment, and we see that the difference is quite obvious. So the UNIS data, as you see here, is the curve where the transplantation or the transplanted patients will survive and maybe most likely better. But we have a problem of giving the transplantation to every of our patients, especially in regard to that we have a waiting list. So the patients on the waiting list also have a problem to reach that goal for a transplantation. And the waiting list is really different in the different countries. I think Germany is different than any other country, most likely, even if it's in the area of the Eurotransplant community. And you see that United States most likely also have an increase of waiting time already. And maybe also Simon can talk about Canada later on if there is an increase of waiting time, especially for those patients in the really critical status 1A. So in Eurotransplant, we saw also this slide yesterday. So there's a number of transplantation, which is little going up. I would be optimistic on 2018. But this waiting list, which is normally nearly double of that patients which can get transplanted heart, and this is for all hearts, and this is not only for pediatrics. So waitlist mortality, there's a nice work on that, which is actual work done by Blackstone, and they said even if you use all the mechanisms you can do, so even if you have medical treatment, full medical treatment, if you have used assist device, there's a waitlist mortality in those patients, which are adults in the moment. There's no study on the pediatric ones. But this nicely shows that whenever you have patients on the wait list, there is a risk even for deterioration in those patients. And they say the risk of mortality is really depending on the organ function. If there is an organ dysfunction or an adverse event, even neurological, so there is a decrease of survival on the wait list, which is really important in regard to the long-term support which we are doing in the moments, reaching 1 year or more than 1 year with the vet in the pediatric patient. I think it's really, really tremendous that we have to deal with these problems, and that we, even if we have the patient on the vet, have mortality on the waiting list. So what are the influencing factors on outcome, even especially in the pediatric heart transplant? I think we have to define 2 steps. So we have to define that part which is before the transplantation, which is most likely really complex already, and we have to define that in regard to the prior history of the patient. So the patient history is most likely that the patient may have a treatment, may have a vet, may have a surgery prior, before, or even multiple vets. And we have also the fact of age. And some of those patients have infection, and as we know that congenital heart disease patients are really difficult to bring them to transplantation because of the prior history, especially of the prior surgery and all the things we do. So we see that all these factors, and especially those are coming together with immunization, are really depending or making it more difficult to bring these patients to transplantation, because the risk is increasing with all these factors. Then there's a part after transplantation, which is telling us that we have the same issues again, most likely. We have the risk of infection. We have the risk of antibodies. So we have the risk of bleeding, especially in the early phase of transplantation. Again, regarding on the prior therapy, especially if we have a vet or if we have a patient which has multiple surgeries before. And then we have, in the long term, the risk of the immunosuppression. So this now is added to that patient. So the risk of immunosuppression means all the side effects of immunosuppression, again, including infections, including kidney problems, including tumor problems. So all this comes together, especially after transplantation. So we have a special issue. So there's a number of possibility of risk factors over here, but we have most likely the more priority on the pediatric part, which is most likely the age, the congenital heart disease, the diagnosis, the prior surgery, and mostly the immunization according to transfusions, according to homograft implantations, or even any other issue. And then we have the delay of growth and the retardation of the body weight and height, which is really especially difficult to take over or even to improve afterwards, after the transplantation. So there are special risk factors, especially in the community of congenital heart disease. So it is described that Fontan is an increase of mortality. So if the previous Fontan operated patient is bridged to transplantation, then there is a higher risk for mortality itself. It's not in regard to the individual patients, but it is most likely according to all the history of surgery, transfusion, and especially also the organ function, most likely in those patients, liver, kidney, and all the things. So chronic congestion may cause a difficult situation before transplantation, especially. But then we have the risk of immunization, which is really a high risk on those patients. A lot of surgeries, a lot of transfusion may really increase the risk of immunization. So those patients are at risk after the transplantation, especially because they take their risk over the transplantation, and especially with all immunological problems going on afterwards, even with immunosuppression, there is a risk that they attack their graft and that the graft failure is earlier than in other patients. And then there is a risk of collateral flow, autopulmonary collaterals, which are sometimes really tremendous in this patient. It's also described that those are the risk for early and also for bleeding, but also for early graft failure in the beginning because of the hyperperfusion on the lungs and especially on the return of flow according to the heart. And according to the International Society of Heart and Lung Transplantation, they figured out again that several risk factors are influencing mortality and especially outcome after transplantation. And you see that the diagnosis of congenital heart disease again is influencing that retransplantation versus dilated cardiomyopathy, but ECMO and dialysis. So all the things which are sometimes happening in your patients are increasing the risk and decreasing the outcome. So, but let's go back a little on that, what we had and what we have on history especially. So this was a part of the keynote which we wanted to do before, so that's why I a little take over that part and try to update you, most likely according to that 50-year jubilee. You mostly have heard that in the past in 2017, but that's where it started in the 3rd December of 1967. That's where it started. So this was the first transplantation, human transplantation in South Africa. And you see that the patient was a 54-year-old male and received a heart of a 24-year-old woman after an accident. And this patient was successfully transplanted. But in regard to that area, the immunosuppression which were used was really limited. So the number of medical drugs which I can use in regard to immunosuppression was really not that many. It was steroids most likely, and maybe azathioprine. So what they did is also not understand that even if the heart is transplanted, that there is a risk that the heart is not accepted by the recipient. So that's why a lot of information was not there in that moment, but technically this was a nice thing of that. Technically it was possible and was described and done afterwards or repeated by several people. So, so this was a news, and again today I think also sometimes it's still a news that transplantation is possible because it's such a, let's say, a special operation and a special need for that organ is transferred to a patient, and I think really that shows us. And it seems to be that there's a success on technical part. And the first pediatric transplantation was done 3 days later, on the 6th of December, in the United States. So there are a couple of people working on that part to transplant organs, and especially research was done before that in several animal studies, and a lot of things were going on separately in many countries. So, but those doctors like Christian Barnard and Kantrowitz, they were able to do that in a clinical setting. And as we see here, this patient survived only a round of 6.5 hours. So again, this was done under deep hypothermia, but they tried to do their best to do a technical improvement on that part and to make it possible, just the transplantation itself. So if we go to history then, we see that in 1967 it started with the 2 first transplantation, and then the success and the survival of that patients are 18 days or 6.5 hours. So after that, there was a discussion on, and there was several more transplantation, even with the same outcome. Within a couple of days or weeks, this was the outcome of this therapy. So that's why everybody said this is not possible to continue with that, because we mostly don't understand why we can technically implant the heart, and the heart is working, but even in the long term, there's a problem on that heart function especially, or we have problems with other issues, especially infections, if we try to increase the immunosuppression in this patient. So that's why the numbers went down. Overall, this is the number of overall worldwide transplantation, 68, 99, 47, and then it goes down to just a couple of every year. And this was the reason why all the countries intended to do more research and to understand why the heart was not working in the long term, and especially how to solve that problem. And then at a certain part in the 78s and 80s, so there was a development of a medication which seems to have impact on the transplant outcome, especially, and that's what the research base was, and especially what there was a fear of, that the heart is not accepted by the recipient. So the difficulty of understanding rejection was more and more coming up, and there was a need for treating this rejection especially. So with this medication, the transplantation process again started over, and the transplantation was again also now defined as successful by outcome. So they started to discuss or even report the first successful transplantation in regard to outcome. So survival was now the most important part. And as we can see here, in 1984, the first successful child was transplanted with a survival of 6 years, get retransplanted afterwards and survived as long as I said here over 22 years. So this was a successful transplantation and started in the 50s, 85, 84. Then there was the xenotransplantation trial. So this was done also in 84. So they wanted to understand if this make a difference. And I think we have a good talk later on about xenotransplantation especially, that if this is an alternative in regard to survival, especially because I think technically it's possible, but survival, again, all the immunological things are really difficult to understand, especially to solve. And then we have the first pediatric transplantation in Germany, 85, and then it started over to get improved in regard to outcome. So outcome is now really important on reporting the success of pediatric and even also other transplantations, organ transplantation especially. But we can see here that it started in the 78 early, that survival was reaching now more than 5 years and increasing over time, as in the last years, even increasing until 2000, around 10 years and more afterwards. So this was really important, that there's a learning curve and there's a special need for improved of making those patients surviving. I want to figure out that the development of cyclosporine was really impacting on that, especially. The second is that there was a detection possibility of understanding rejection. So they standardized the possibility of pathological specimen. They were understanding that they have to take it from the donor heart and that they have to make a therapy decision on that. So this was done in the 70s, most likely. And afterwards, we have further development of immunosuppressive drugs. So that's why we also can improve now the survival, I think, with that drugs in our pocket, because we have a choice and we can most likely individualize those therapy in our patients. Overall, all organ transplanted have improved of outcome, so improve of survival. And if you see the decades over here, so the yellow one is those actual one, and you see that this curve is mostly much better in all organ transplant. It is not related to heart, but if you then see on the heart, it is really seeing that the long-term survival is even lower than all the other organs which are transplanted. But nevertheless, I think still we have to improve that, but it's still also, it is improving. So with all the things and the side effects, we have to solve that problem especially. So in United States, which is not only the ISLT data is not only United States, it's worldwide, but the majority of patients included there is in United States and Canada. You can see that the number of patients are depending on, and you have the majority of patients are dilative cardiomyopathies. We have a small number of other, and we have 20% of congenital heart disease patients. So these numbers are mostly the same. So the congenital heart disease patients are the same, and it's a little higher, especially in the United States. So in North America, and excluding Canada, it's around the double. So it's 40% on the congenital part. So these patients are more often in North America transplanted than in Europe. So what is now happening according to the decades or even to the time? What is our learning curve especially? And I think again this data, this biggest data, possible data which we have is showing us that we have in the younger period, where this is the last 7 years or even 9 years now, that we have a better survival on that curve in regard if we compare to the older area of the beginning of transplantation especially. So I think this difference makes sense. This difference is related to that we understand more and better how we solve the problems. Also that we decrease the side effects and the problems related to the immunosuppression especially, which is a big factor in pediatric transplantation, and that we can protect the graft from rejection and especially graft allovasculopathy. So Oliver showed us yesterday that the weaning curve is much better still than in comparison to the transplant population. But I think we have to be clear that we hopefully can make this curve as long as it is here in the weaning patients, and hopefully we can solve that in the future. But we have also some other factors influencing outcome. Outcome is influenced by age, especially in the pediatric transplantation group. So the group of the younger patients most likely are better, have a better outcome, and the patients group which is transplanted at the age of 11 to 17, which is the green line over here, and also the 6 to 8, those patients have a decrease on long-term survival. So they really have some problems, maybe some compliance problems, maybe some others. So there's a lot of discussion on that, but those patients are especially at risk in regard to the long-term outcome. So just quickly look at our data. Out of 290 patients, the majority of patients are dilative cardiomyopathy patients in our center. And the number of transplant is really different over the years, but around to 5 to 10 every year. That's what we normally do. We can see there are bad years and there are better years. Overall, we see also a change of outcome in our patient group, especially. So in the early years, we have a much more lower decreasing Kaplan-Meier curve on the area of 1968 to 1999, and there's improved survival on the actual in the last maybe 10 years especially. And if we now think about just picking out the 2001 to 2018 patient, then we see that we have an improved survival and that we are not reaching the 75 percentile in the moment, so which is showing us that we have really an improved outcome in our patient group especially. How this come? Most likely we try to figure out what are the problems. Especially the early mortality is really depending and showing us that we have a problem on bleeding most likely. We have a problem on the early phase of treating the patient. And our surgeon improved their techniques, and the possibility of intraoperative solutions are also, I think, improved. And the number of patients stabilized with a VAT before transplantation are also increased. So the number of patients transplanted from ECMO is really, really rare in our center, and especially. So these are the intraoperative, the perioperative problems maybe which we can solve. But secondly, we have improved and changed also our protocol in regard to immunosuppression. So in the beginning, it was the major issue and the major goal to protect the graft and to let the graft survive. So that's why we increased our immunosuppression on a really high level, especially in the early phase and also in the long phase. But we have to understand that the pediatric patients are different in regard to what they need. So there's maybe some kind of different approach in that, in regard to tolerance and maybe in regard to accepting the organs. So many patients need high immunosuppression, but some not. And those patients have to be identified by a clearly specified regimen. And we have to figure out if those patients can have a reduction on immunosuppression over the long term. So that's why we have to look on these patients individualized. And especially that's what we did. So we learned that even if we do a lot of antibody therapy, we might have the side effects of that, especially the tumor and the other problems. And if we keep the toxic medication as high over a long time of period, then we have all the side effects in regard to them. So that's why our goal is to reduce toxicity in our patient and to individualize especially the immunosuppression. The influence on assist device was not related in our patient survival. So if the patient was transplanted from VAD, which the number are still increasing in our center especially, or not, it's not influencing our mortality in the long term. So it's most likely that just the early mortality which is not significant. So just look briefly on the course of transplantation. So the possibility of all these events is there. So we have in the early phase the infections, especially bacterial and viral. We have in the early phase the risk of acute rejection. And we have the problem of early graft failure, which is most likely a hyperacute rejection on the graft or an anatomically or surgically problem. So this is the fact which we have in the early phase. And on the long term, we have all this which you can see here, which is again, the rejection still is there, but the rejection numbers are really decreasing over time. But we have the problem of graft dysfunction according to the vasculopathy. So the cardiac allograft vasculopathy is really influencing our long-term survival especially. And then we come already in the pediatric population to tumor and the side effects of medication. So these are major issues which we have to solve. And over time, you can see here the numbers of vasculopathy is increasing over time, especially if we look on long-term follow-up. the graft failure is decreasing, which is the early graft failure, and then the graft failure is mostly related to cardiac allograft vasculopathy. So this part is mostly adjacent to each other. It's not really clearly defined if the graft vasculopathy is there, or if it's a graft failure. Most likely it's both, or it's a rejection-related graft failure. So, and then we have the phase of infection, which is on a low level, especially in the pediatric population. And again, this figure showed you maybe the difference on the patient groups in the 5-year follow-up. So the graft failure is the same in the adult population, the pediatric population, but the cardiac allograft vasculopathy is a little higher in the pediatric population, and the tumor rate is around 10% in the long term. But this is not all the PTLD, so the lymphatic tumors is not only in that part in the adults. Is more like any tumor which you can have in the long term in the age-related proportion, and these are the tumors which are mostly lymphatic. So we have a difference of tumor risk in the patient group, especially in the pediatrics. So we always ask, what is the road to success if we transplant a patient? Nevertheless, I think we have to increase our surveillance, and as we see from history, we have to learn what is the influencing factor in our patients. So if we have a problem on side effects, we need to decrease medications. If we have more rejections over time, we need to increase the medication most likely, or we need to reduce the risk factors in these patients. So that's why I think there are 3 major issues. So screening for rejection is nevertheless needed. Screening for vasculopathy is nevertheless needed. And most likely screening for tumor, but also trying to prevent tumor, which is a major issue, is needed in regard to your surveillance on the patient. And if you do that, I think you're really happy and you really increase the outcome. So just briefly, what's possible for rejection treatment, for rejection detection? So rejection can be detected by several methods, non-invasively or more invasively. So EKG, echo is really important, I think, in regard to the non-invasive detection of rejection. But still, nevertheless, it's not showing you the full picture. So at a certain part, you have to do a biopsy, and especially that is not 100% specific or sensitive. But I think we hopefully have different possibilities in the future. But echo is in our center the majority of the majority of method of detection. Whenever there is a change of echo, systolic function, diastolic function, regurgitation, or even in tissue Doppler there's a change of wall movement, then I think rejection has to be suspicious. And we do biopsies in our patient, especially also routine biopsy, because we see always again that all the other methods are possibly negative. Echo is normal, EKG is normal, patient is good, but we see that there are slight rejection going on, and especially those have to be figured out in regard to the treatment course. So if we see rejection, we will not lower down the immunosuppression in our patients, but if we see no rejection, we might have the next step to do, lower down the immunosuppression especially. So that's why we have increased most likely our numbers of biopsy. Some are related to the diagnostic, and some are also routine biopsy, normally after 1, 2, and 3 years, and then maybe afterwards in regard to the patient itself. So I think there are new options. MRI is telling us that it may better and better detect rejection. So T1 mapping, I think, is one option, and it's showing us that in the especially adult population, but also in pediatric, it is made possible to detect that with the MRI. In our center, it is not possible for a long time because we had implanted non-invasive detection machines with a pacemaker, which we're not able to do MRI, but now we can do. And I think this is nearly there that we can use this most likely as a routine screening in regard to especially biopsy. And this is a nice example of what is possible with the MRI from our center. It's adult patients. Was provided for RF gapectomy. You see that the systolic and diastolic function especially is decreased in these patients on both sides, and this is before the treatment and this is after the treatment, and you can see that this is matching with the T1 mapping. So the edema is detected by T1 mapping and is especially most likely related to the inflammation of the heart. So I think if we more and more introduce this in our clinical workup, I think we are most likely have possibility also again to reduce the numbers of biopsy especially. There's another opportunity which is more complex to do microperfusion analysis in MRI. I think this is also maybe coming up in the future. This is in the patient where the microperfusion is reduced in regard to the tracer and the things they do with adenosine to see what the microvascular is doing. But I think after transplantation, especially 8 days after transplantation, this is not related most likely. Rejection most likely is more, again, ischemia reperfusion injury, and that can be detected especially also by other methods. But nevertheless, a possibility. So, as I said before, in the beginning we had only a couple of medications. Now we have much more medications. So that's why we can choose what is the best medication and the best combination, especially in our patients. And that's why I think still there are some medications in pockets in the pipelines. So then we hope that we have a more specific possibility to targeting the immunosuppression on our patients. And one breakthrough was the introduction of mTOR inhibitors. And I think really that makes our life much easier, and especially in those patients which have risk like renal dysfunction, tumor. All those patients can be better treated with these mTOR inhibitors, I think especially. And those patients also can be maybe preventively treated, which have cardiac allograft vasculopathy. That's what we try to figure out in long term, especially by imaging. But nevertheless, I just wanted to show you what's possible in regard to that we can individualize our immunosuppression. So we just compared 3 different groups on our center, which is the standard protocol, a normal calcineurin inhibitor plus antimetabolic, and then we have a reduced group where we reduce the calcineurin inhibitor, and then we have this group where we put this calcineurin inhibitor away. So this is off-label treatment, nevertheless, but it is mostly indicated in the patient which have really a lot of side effects. And overall, the post-transplant time was significant, little different, and also the age, but all the other issues were not mostly related. But in the long term, we see that those patients which get off the calcineurin inhibitor have the better survival, especially because we reduce the side effects. And those patients get surveillance biopsies and surveillance examination on the coronaries, where we see there is no change at all over time. So they have no rejection in the long term. They have no decrease or increase of cardiac allograft vasculopathy or even cardiac function. So that's why we think this is possible to individualize in the patient. And the allograft vasculopathy, especially the Achilles heel of the transplantation, because it will come in the long term. You cannot prevent that in any of those patients. The only question is the intensity of cardiac allograft vasculopathy in your patient. How high or how low is this? And especially if you see that, you can have a lot of imaging. I will just briefly go through this. I think the majority is in the moment doing ultrasound. We intended to do, since more than 6 years, the near-infrared method and the OCT, and especially with that, you can see what's happening in the vessels. And what you want not to see is such angiography where you already see a progressive cardiac allograft vasculopathy in the patients. And you can see that the vessels are really have different lumens, obstructions, and they have different sizes. And if you see local changes, you can treat them. But if you see such a diffuse picture, as I showed you before, there's no possibility to treat those patients. And the graft will fail over time, maybe earlier, maybe later, especially in that time. So the treatment options are only in those patients where we have focal stenosis, so only one stenosis or really slight stenosis on those patients. That's the option. So that's why we detect that. In our patients, we wanted to see not the vessel filled out by the contrast medium. We wanted to see what is happening really in the vessel wall, and that's why we use this method. This is a small catheter which goes into the coronary artery, as you can see here, and then we get this nice picture of the wall, of the 3 layers of the wall, and normally we wanted to see this, that there are 3 layers, no intima media hypertrophy, no change of vessel lumen wall diameter. And if we see that we most likely will not detect that by angiography, because the angiography is just filling out the lumen. So the lumen will maybe look still normal if you see slight changes, or even that slight changes over time. So those patients have to be prevented by treatment especially. There's a last issue. This is tumor. It can happen in every organ. That's what we learned over time. And especially it is related to EBV in the pediatric population. And the risk is antibody treatment, especially if it's a more pronounced antibody treatment, not the induction therapy, that is clear. But if you have more and more according to rejection episodes, or if you have a really intense immunosuppression, and it is difficult to treat, but you have to detect it early as better, and that's why we have impact on our survival curve by this tumor development over time in regard to what we see. So these patients with the PTLD have a decrease of survival, which is not related to the transplant again, or to the heart again, so it's mostly related to the immunosuppression. But we improved our protocol of screening, and we improved our protocol of immunosuppressions over time, and that's why we see also an improved survival now in the patient with PTLD. And we have, according to that, changed our immunosuppressive protocol. We changed the antimetabolite, especially used more mTOR on this patient, and secondly, we changed also our induction protocol in regard to decrease the risk for PTLD in the pediatric patient, especially if there's a possibility to use a different antibody. At the end, after several years, maybe 10 years, maybe 15 years, we see that picture. So the patient can have a deterioration of ventricular function, which is not possible to treat by any options which we have. So immunosuppression is optimal. The graft is looking as we see. The vasculopathy is maybe not that severe, but we can still have this picture of graft failure. And the graft failure is mostly related to a restrictive physiology of the graft. So there's a restriction, there's a stiffness, and there's a regurgitation mostly on the AV valves, and then there's all the picture of RV failure, LV failure, and that's why we have to solve that by mostly the retransplantation. And especially in this child, there was a need for a BIVAT after several deterioration and decompensations over time. And 7 months on BIVAT, he went on the second transplantation. It was 10 years after his first transplantation, according to acute graft failure, which we are mostly cannot sometimes understand also especially. The numbers of retransplantation internationally is around 4 to 6%. It's not that many over the years, so it's not increasing, interestingly. I think that's mostly related to the improvement of outcome. So where are we today? Transplantation is possible, but we need to individualize our immunosuppressive protocol, especially in the treatment. We need to be alert for rejection. We need to be alert in regard to cardiac allograft vasculopathy and tumor. And if we look for all these three things, I think it's possible to improve outcomes still in the moment and to make these Kaplan micros better. So the goal is adapted immunosuppression, lowest possible immunosuppression. On every step of surveillance, we ask about, can we lower down? Yes, we can or not. Then we decide on that. We need to have improved immunological monitoring. We just measure the blood levels or the trough levels especially. And we need to, I think about that we mostly can also get rid of the calcineurin inhibitors in the long term in a separate group of patients. We have the risk of antibody and immunization, and Simon will follow with this talk about that, and I think that's really now again influencing our outcome. So the outcome can be related to that, maybe again decreased because we have high-risk patients, bringing them to transplantation. We need to solve that problem, but still antibody and immunization is a big issue now in the, let's say, more pronounced transplantation. There are a couple of issues which we may have in the pockets in the future as a regard to specific treatments, but this is my conclusion. This is a nice work from Kittelsen. He tried to think about what is in the current area, what are the challenges which we have to solve. On the left side, first of all, it's a limited donor supply, so we have to talk about extending our donor pool, especially with several issues which we can have. And we need to talk about how we can better bring the organ to the recipient, especially in the long distance and the short distance, even include the preparation time in the Gooch patient especially. So all the issues are here. Secondly, what is if we have candidates with increased medical complexity? This is all of our congenital patients, so they have the risk of immunization, we have the risk of rejection, and we have to think about how we can solve that problem especially. And with that, I would like to finish and thank you very much for your attention.